Hi, I'm Dr. John Ellis, and thank you for spending time with me as we discuss critical race theory, and in my case, as it applies to disparities in healthcare in general and anesthesiology specifically. And you may get these slides if you wish at this URL, which is Ellis_CRT. I'm an adjunct professor at the University of Pennsylvania and visiting assistant professor at the University of Miami. I have a financial relationship with Health Innovations Capital, where I'm on the investment committee. It doesn't relate to my topic here today, and my presentation does not include a discussion of off-label or investigational use of drugs or devices. My objectives are identify causes of socioeconomic status and links between those and health outcomes, to describe racial disparities in health status, health care, and specifically in anesthesia and perioperative care, and discuss tools that may be used to reduce the impact of clinician implicit bias on patient care. Well, first things first, what is critical race theory? Critical race theory is a legal scholarship theory that's been quite in the news lately, but of course has been distorted in a lot of the recent media coverage. Dr. Kimberly Crenshaw, professor at UCLA and Columbia, is one of the originators of this, along with Derek Bell, the late Professor Derek Bell. And what is it? Critical race theorists reject the philosophy of color blindness. They acknowledge stark racial disparities that persist in the United States despite civil rights reforms, despite legal rulings, despite legislation, and question how racist hierarchies are enforced and how we can do better. And they are mostly concerned with institutions and systems and not necessarily the actions of individual bad people. In the interest of time, I won't play this video by Dr. King, but I urge you to go back and watch it. And he talks about some of the structural aspects of the government's involvement in racism that have been detrimental to African Americans. In that speech, he talks about government effects on depriving Blacks of agricultural land and other land. We also know that after World War II, the government sponsored education, sponsored housing loans, sponsored urban renewal and highway construction, which also often demolished Black neighborhoods, and yet the government funded suburbanization that often, usually explicitly, excluded Black citizens, and even Social Security initially excluded agricultural and domestic workers who were often African American. In 1954, the High Court banned racial segregation in public schools, and yet we see in the South that desegregation reached its peak in 1989 and has actually continued to fall since then. And as I say here, don't get it twisted. The North is no better, and in some ways is even worse. If we look at the racial wealth gap, this is over many decades. We see here that nothing has improved in terms of the white-Black ratio of wealth, really from around the turn of the previous century until today. The government provided loans after World War II for housing and thereby provided wealth, generational wealth to many people. In Northern California, 350,000 homes built. With these loans, less than 100 went to African Americans. Redlining, where specific areas were deemed not worthy of having government-backed loans, were often, usually, areas where Black and brown people lived, therefore deprived of the opportunity to build wealth, whereas the government provided that for other people. What does this have to do with health? Well, to a large extent, health is wealth and education is wealth. So we know that people who are richer live longer and have better health status, and people who are more educated live longer and have better health status. And this is true even in countries that have universal health care, such as Finland. We see that as people get richer, their health outcomes improve. We see this in the UK, as people get richer, their health outcomes improve. And in fact, if you're going to be poor, your health outcomes are better in the UK than they are in the US. UK has universal health care. We in the US do not. And I said, don't get it twisted about North versus South. I live in Chicago. Chicago has the largest gap in life expectancy for a metropolitan area between the census tract with the highest and the lowest. So if we go here near Northwestern Medical Center, average life expectancy 90 years, 8 miles to the south, In Englewood, 30 years less, only 60 years average life expectancy. Now, what about when we get to the actual realm of healthcare and healthcare delivery? Are Black patients treated differently? And the answer is absolutely yes. We see that, and this is from the 1619 project, that myths about physical racial differences were used to justify slavery and are still believed by some today. This is a survey at the University of Virginia where I did my residency. It showed, these were mostly medical students, that many believed that Black skin was thicker and that Black patients were more impervious to pain. This imperviousness to pain was deemed justification for punishment of slaves because they were considered to be insensible to pain. And yet we see 150 years later, we see when pediatric patients have long bone fractures or suspected appendicitis, very definite medical conditions, Black non-Hispanic, Hispanic, and other patients are less likely to receive opioid analgesia than majority patients. And the AAMC has an article a year and a half ago that summarizes some of the ways that we fail Black patients in pain. We find that Black patients are often described in medical charts in negative ways. This is an article that was just published this year from my former colleagues at the University of Chicago, and found that these negative patient descriptors, you see some of them here, were 2.5 times more likely to be found in the charts of Black patients compared to white patients. Perhaps even more concerning is a classic study by Schulman 20 years ago, where there were actors describing their symptoms of chest pain to physicians at a meeting and asked the physicians, internists, and cardiologists, would you refer this patient with chest pain for cardiac catheterization? And we see here that women were less likely to be referred, Black patients were less likely to be referred, and Black women were particularly much less likely to be referred. And one might ask the question, would we find similar issues in the rate at which patients are referred for preoperative cardiac evaluation before major surgery? We don't know the answer to these questions. This is fertile ground for research for junior faculty and trainees. What we do know is that surgery takes longer in Black patients. This was shown by Jeff Silber and Lee Fleischer. Subsequent work showed that Black patients were more likely to have their operations in hospitals where surgery took a good bit longer than other hospitals. If you look at colorectal surgery, we find disparities in terms of higher mortality, longer post-op length of stay, and more readmission after colorectal surgery. Work from Duke suggests that Black patients are more likely to be malnourished when they come for colorectal surgery, which may contribute to some of this and may suggest room for improvement in terms of preoperative preparation. Obstetrics, this is a tremendous problem. Black women have 3 times the maternal mortality. Texas is really a laggard in this area, but this is true in many states, and we see this has actually increased during the pandemic. And so 2018, 2019, 2020, maternal mortality for Black women 3 times that of white and Hispanic women, and just something terrible that we need to do better at. One of the things we see that Black women are less likely to receive epidural analgesia for labor, even after you adjust for all of these factors here on the right. Other work has shown that Black women are more likely to receive general anesthesia for cesarean delivery. And again, this puts them at higher risk for adverse consequences, and even more so in the era of COVID-19. We can see issues in the realm of pediatrics as well. Joe Tobias and his group at Nationwide Hospital in Columbus, Ohio, has shown that in Black children having surgery, 3.5 times more likely of dying within 30 days. And on subsequent work that was published in ANA, they showed this was due to failure to rescue following unplanned reoperation in pediatric surgery. This is something that must be addressed. And yet what we see is that Black children are adultified in pediatric anesthesia. That is, people think they are older than they actually are. They're less likely to be offered choices like the presence of child-like services, parental presence for inhalational induction or pre-medication before surgery, less likely to be offered to African-American children. What can we do? Well, Peter Drucker, the management guru, would say what gets measured gets managed. And so we need to measure better. So for example, David Rich and the group at Mount Sinai in New York showed that if they did data-driven interdisciplinary interventions, they could improve inpatient pain management. And one of the things they found is that severe pain was more likely in African-American patients, but then they had defined protocols for how severe pain was to be treated. Another example of this is in colorectal surgery. This group found that when they implemented an ERAS protocol, they were able to bring length of stay down in all groups, but particularly in Black patients. So you can see what they use: acetaminophen, celecoxib, gabapentin, and intrathecal morphine. We see before ERAS, Black patients were staying almost 3 days longer than white patients. After implementing ERAS, you see this is almost a 4-day difference in length of stay of Black patients. So consistent applications of protocol and guidelines may be particularly useful in analgesia, but also improving outcome. And some might say, okay, well, then we should do machine learning and use artificial intelligence to improve the care of patients across the board. And that is true with some caveats. This is from Health Affairs last month. You have to have good data to identify target outcomes and predictions. We all know that there is diabetes and diabetes. And so you just can't have measurement of diabetes, yes, no, but you must incorporate measures of severity of disease. Professor Mulanathan, university professor at University of Chicago, showed using an insurance database that using their insurance database for identifying patients who needed intensive chronic care to reduce expense and reduce hospitalization, they found that at a given risk score, Black patients were considerably sicker. Why? Because what was the risk score based on? Healthcare spend in the previous year. Well, Black patients didn't get as much care. When they actually look at clinical indicators and not just financial considerations, they found that the percentage of patients who needed additional help was 17% patients, 17% Black patients if money was the index, but went up to almost half if severity of disease drove these decisions. So again, there's diabetes and then there's diabetes. They're not all the same. Now, recently, we've seen some studies that suggest racial concordance of patient and physicians may result in better outcome. This has not been shown in anesthesia, but it has been shown, as I'll show you, in newborn care, and has also been suggested in getting patients to comply with recommendations in general internal medicine. This made the news. This is CNN from 2020. Black newborns more likely to die when looked after by white doctors. I'd prefer to say that they're less likely to die when looked at by Black doctors. And this was actually published in PNAS. And this is the mortality: Black patients cared for by Black physicians, white patients cared for by Black physicians, Black patients cared for by white physicians. Now, I don't know of any literature about racial concordance in anesthesia. This is obviously difficult to do. 3% of US anesthesiologists are African American versus 13% of the population. This is my dear friend, longtime colleague of over 40 years, Dr. Bill McDade. He is an anesthesiologist, and he is the first Chief Diversity and Inclusion Officer at the ACGME. And his mission is to make sure that we have the physician workforce that can provide care to match the patient population that we have. And so we will conclude here by saying that equality is our last hope. When caring for Black or brown patients, clinicians should ask a simple question: if this patient were white, would I treat them differently? Or I might say, if this patient were my family member, would I treat them differently? James Baldwin was quoted saying the following: I love America more than any other country in this world, and exactly for this reason, I insist on the right to criticize her perpetually. So thank you for spending time with me. I'm John Ellis. You may download these slides, and this URL is Ellis_CRT. Thank you so very much.
Good afternoon, everyone. I'm delighted to be here to contribute to this panel and to be a part of this important discussion. My goal today is to shine a light on how our institutions and systems have been designed in ways that have produced and perpetuated marginalization of certain groups. We'll discuss historical examples of medical racism, how bias has been reinforced in medical education, and we'll review the root causes for the lack of diversity in academic anesthesiology. This is a complicated story to tell, but it's important to amplify the perspectives of folks who've had lived experiences of marginalization. We should take an honest look at our history to understand how we got here. The very beginnings of this country involved the genocide of Native Americans. Then for over 300 years, we engaged in a brutal practice of kidnap, enslavement, and forced labor of 6 million Africans who were frequently subjected to torture in order to maintain control. Although it's been 150 years since the Emancipation Proclamation, involuntary servitude continued for another 100 years with abusive sharecropping practices. At the end of Reconstruction in the 1870s, lynchings of Black people only accelerated, essentially domestic terrorism meant to enforce white supremacy. And this practice continued into the 1960s. Jim Crow, legalized segregation, was the law of the land in the South until almost 1970. The Ku Klux Klan is still active today, and the Charlottesville riots of 2017 are evidence that white supremacy is alive and well in America. Medicine was an integral part of the story of slavery. Robert Dunglison, known as the father of American physiology and doctor to presidents, wrote an influential textbook. He espoused racial inferiority theories, which he presumably shared with founding father Thomas Jefferson, who had a notoriously contradictory attitude to racism. He was able to pen that all men are created equal while also owning 600 slaves in his lifetime. He believed that Black people were much inferior and thought that Black people had a dysfunction of their pulmonary apparatus, a sign that Black bodies were fit for the field and little else. This scientific racism likely contributed to the treatment of non-whites as perpetual others and outsiders. In the 18th and 19th century in America and Europe, there were regular public displays of humans in zoos, the focus being to emphasize the inferiority of their exhibits. There's abundant documentation of slave experiments in Southern medical journals. ACOG has acknowledged the troubled history of Marion Sims, known as the father of modern gynecology. He repeatedly operated on slaves who could not reasonably consent, some of whom he bought for that purpose. He conducted these surgeries without anesthesia to perfect his vesicovaginal fistula technique. He went on to perform these perfected techniques on white women who would only accept the treatment if anesthesia was utilized. He's less well known for his experiments to treat neonatal tetanus, which he hypothesized occurred because of skull bone movement during delivery. His experiment using a shoemaker's awl to pry open the skull bones of these infants had a 100% fatality rate. A Virginia enslaved man, John Brown, escaped and dictated his memoir. He recounted being experimented upon by a Georgia physician, Dr. Thomas Hamilton, who was studying heat stroke. He subjected Brown to sit naked in a burning pit while trying out various medicines and remedies to revive him as Brown faded in and out of consciousness. Brown also reports that Hamilton attempted to determine how deep Black skin goes by blistering Brown's hands and feet. A North Carolina physician and slave owner, William Aiken, reported experimenting on a slave named Lucinda in 1852. Lucinda had a bony growth around her eye. Aiken and other doctors bored holes in her head without anesthesia to remove the growth. Hospitals would post newspaper ads for owners to send sick or injured slaves to be used as materials in clinical instruction. As American medical education expanded in the 19th century, Black bodies were disproportionately targeted for anatomical dissections. The most famous of these were in Baltimore, where grave robbers, so-called resurrectionists, would dig up bodies to meet the needs of the surrounding medical schools. There was outcry, but it took some states until the late 19th or early 20th century to outlaw the desecration of graves. The American eugenics movement began in the late 19th century, but continued into the 1940s. The goal was to eliminate undesirable genetic traits through selective breeding. This resulted in legalized forced sterilization, primarily affecting minorities and people with disabilities. John Harvey Kellogg, best known as the doctor who invented Kellogg's cornflake cereal, was also an American eugenicist. He focused mainly on race degeneracy, as he believed racial mixing and mental defects would damage the human race. He organized the Race Betterment Foundation, which had a pedigree registry and hosted national conferences for years. The American eugenics movement inspired Nazi Germany. In his book, Mein Kampf, Hitler mentions American eugenics and how successful the sterilization laws were in California. Hitler directed thousands of people to be sterilized who did not fit his ideal of the Aryan race. This evolved into the genocide of millions of Jewish people. Dr. Joseph Mengele conducted at least 70 medical research projects involving cruel and often lethal experimentation on human subjects in Nazi concentration camps. Most of you will be familiar with the Tuskegee syphilis study, a 40-year experiment run by the Public Health Service following 600 rural Black men in Alabama with syphilis over the course of their lives. Officials refused to tell patients their diagnosis and refused to treat them for this debilitating disease. Whistleblowers brought an end to the study in 1972. The venerated Dr. Jonas Salk, who would go on to invent the polio vaccine, was co-author for a federally funded study begun in 1942 that injected experimental flu vaccine in patients at a state insane asylum in Michigan, then exposed them to flu several months later. The book, Acres of Skin, documents clinical non-therapeutic medical experiments on prisoners at Holmesburg Prison in Philadelphia, conducted under the direction of dermatologist Albert Kligman, who died in 2010. The title of the book is a reference to Kligman's reaction on seeing hundreds of prisoners when he entered the prison. The University of Pennsylvania has issued a statement where they're announcing that it's appropriate for them to re-examine how they recognize Dr. Kligman's legacy. Once the availability of mentally ill patients and prisoners dried up for research, pharmaceutical companies moved overseas. Pfizer studied an antibiotic, trovafloxacin, of unclear effectiveness among Nigerian children during a 1996 meningitis epidemic. 11 children died and scores more were disabled. Pfizer ended up settling a lawsuit for $75 million, but admitted no wrongdoing. In the 1940s, American scientists infected prisoners and patients in a mental hospital in Guatemala with syphilis, and this was to test whether penicillin could be preventative. After Richard Nixon resigned, rumors began circulating about Project MK Ultra. These were experiments at the CIA that are the subject of a Netflix documentary. The experiments were conducted on unwitting US civilians, intended to develop procedures and identify drugs like LSD that could be used in interrogations to weaken individuals and force confessions. The CDC admits to using an experimental measles vaccine in minority children without disclosing this to their parents. That study ended in 1991. The way we spend research dollars is revealing about what we value in society. Sickle cell disease, despite the genetic basis having been discovered 30 years before cystic fibrosis, despite affecting 3 times as many as cystic fibrosis in the US population, receives about a third of the federal dollars, which probably explains the lack of organization nationally in treatment of the disease and the delay in development of effective drugs. Having discussed these examples, it should come as no surprise what underlies the distrust among people of color regarding research and medicine in general. During the COVID pandemic, Dr. Susan Moore complained publicly about what she perceived as racist treatment before she died. Biases in medicine are so prevalent we don't even notice them anymore. This illuminating article in the New England Journal of Medicine highlights equity concerns in the use of race in clinical algorithms. They hint falsely that race, which is a social construct, results in biological differences. As an example, the original VBAC calculator predicts lower success of vaginal delivery for anyone Black or Hispanic, making obstetricians less likely to offer them a chance at the benefits of trialing vaginal delivery. The good news is, a new accurate calculator that excludes race and ethnicity has been developed by the same researchers. We're beginning to recognize the ways in which medical education is perpetuating physician bias. These investigators identified 5 domains in their institution, issues such as pathologizing race, or teaching about prevalence of disease like higher rates of asthma among Black people, without providing the context of structural racism, which causes greater exposure to pollutants. A recent study showed that false beliefs about biological differences between Black and white people persists not just among white lay people, but among white medical students and residents. Things such as Blacks age more slowly than whites, or their nerve endings are less sensitive, or their skin is thicker. The fact that this image of a Black fetus became a viral sensation points to the dearth of people of color represented in medical illustrations. This popular site on Instagram with almost 100,000 followers is trying to address this gap by sharing representation of dermatological conditions on non-white skin. Let's look at a broad timeline of medical education and healthcare. The American Medical Association was founded in 1847, before the American Civil War, which ended in 1865. Almost 50 years after being formed, because Black physicians were excluded from joining the organization, Dr. Daniel Hale Williams, a highly respected cardiac surgeon, established the National Medical Association. In 1910, the famous Flexner Report came out. Flexner, who was an educator and not a physician, was commissioned by the Carnegie Foundation for the Advancement of Teaching to assess the state of medical education in the US and Canada. He's credited with raising standards in medical education, but he held problematic racist and sexist beliefs. He believed that Black people should be trained as sanitarians rather than surgeons, and their primary role should be to protect white people from disease. This has prompted the AAMC to rename the Flexner Award. Following this publication, 5 of the 7 Black medical schools closed. Many remaining schools would not train Black physicians due to racist admissions policies, and so this avenue was closed off to many Black folks aspiring to become doctors. One 2020 study doing an extrapolation analysis estimated that if those 7 medical schools had remained open, an additional 35,000 Black physicians would have entered the workforce between then and 2019. It should now be obvious that the deliberate lack of investment in historically Black colleges, that structural racism, is at the root of the lack of diversity in academic medicine. Despite being 12 to 14% of the US population, Blacks only represent around 3 to 5% in academic medicine. Hispanics are in a similar position. Going back to our timeline, the Hill-Burton Act was signed into law in 1946. The bill provided construction grants and loans to improve hospitals. But since it was illegal to discriminate based on race, the act got around this by allowing facilities to be separate but equal, where Black and white patients could be segregated. This stayed in place until the NAACP sued to block it in the 1960s. Speaking of separate but equal, consider how Native Americans were forced onto reservations with the federal government agreeing to be responsible for healthcare. Yet consider the extent to which Indian Health Services is severely underfunded compared to other health systems. There has been progress over time. There was a Civil Rights Act. And amazingly, we have come to a point where the CDC itself has declared racism a public health threat. I hope we'll all be able to commit to addressing the lack of diversity in academic medicine. As we build up the pipeline, take note that it continues to be leaky. Increasingly, Black doctors are being vocal about this issue. We're lagging severely in increasing the numbers of Black and Hispanic physicians, despite the looming shortage. So I'll close with a quote from Martin Luther King Jr., who said, "Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. But on a note of hope, the arc of the moral universe is long, but it bends towards justice. It's up to us to acknowledge the past and reach up and pull down on that arc. We can do more and we can do better." Thank you.
Hello, I am Dr. Tracy Straker, and I'm here to speak with you about the critical race theory and what is it. I have financial relationships with Medtronic Speaker Bureau, as well as Vyaire Advisory Board. My learning objectives are to define the critical race theory, acknowledge what the tenets of the critical race theory are, and to then give examples of the tenets of the critical race theory. This is Professor Derek Bell, also fondly known as the godfather of critical race theory. He was the first African-American tenured professor out of Harvard Law School. And this is him surrounded by many students who really look to him for guidance regarding the critical race theory. These are his colleagues, most notably Kimberly Crenshaw, who we will hear from a little later in my presentation. These three individuals were very, very prominent in his teachings, and even so now, Dr. Crenshaw continues on so even after Professor Bell's death. So a little background. The origins of the CRT stemmed back from the 1960s and 70s, but it wasn't formally organized until 1989. It was an academic movement, meaning that it came out of Harvard Law School. The immediate predecessor for the CRT was actually critical legal studies. And it clearly states law and legal institutions serve the interest of the wealthy and powerful at the expense of the poor and marginalized. Critical race theory tells a story. It's about institutionalized racism and systemic racism. And the fact that with these systematized and institutionalized racist types of behaviors, there isn't a color or a race that's assigned specifically. There is no one that's overtly targeted. However, these laws are written and embedded in our society in such a way that there is overt targeting of specific groups of people. Law and legal institutions in the United States are inherently racist as they function to create and maintain social, economic, and political inequalities between whites and non-whites. There are 6 tenets of CRT, which I will talk about and try to crystallize for you using examples as well as video taken through news reports, movies, and actually commercials. The first tenet is social construct. And what that says is that racism isn't biological. You're not born with it. It's something that you attain and achieve based on the environment in which you live in. And it doesn't target individual people. It's not biased against one person, but it's embedded in our legal system so that it reaches out to large groups of people, where a dominant group of people can actually oppress other groups of people. And they use things and reasons for the exploitation of these other groups, things such as one group is inferior to another, or people are immoral. And this is often tied to religion. And also, you just can't rule yourself. You can't take care of yourself. You need us to guide you. An example of a social construct was back in the 1930s with redlining, where the government literally drew lines around areas that they thought were really poor financial risks. And what happened out of that were that the people that typically lived in these redlined areas were poor people, people of color. And the trickle-down effect was from that were that banks refused to give them mortgages, supermarkets refused to build stores there, and you had food deserts. As you'll see further in my presentation, the effects of redlining. This is a map of Brooklyn. And all the areas in red are the redlining areas. It's interesting that today, Brooklyn has one of the most lucrative and most expensive real estate markets in the United States. But here In the areas that were redlined, supermarkets were not built. And so you had people living with food deserts, using corner bodegas, no access to fresh foods, ultimately trickling down to healthcare issues, morbid obesity, redlining based on your zip code. You were not able to get certain mortgage interest rates. People would not build there. The school districts in those areas were poorly resourced, all from redlining. And you still see today many of the effects of redlining in New York City, in Harlem, above 96th Street. Redlining also took its toll on generational wealth building and ownership for people of color. They were not able to get mortgages, or if they weren't, they were at interest rates that were so exorbitant that they were not able to attain them, ultimately trickling down to the lack of generational wealth within a family, usually families of color. Normalcy. And really all that simply is that racism is the norm. It's nothing out of the ordinary. These are the things that people or most people of color experience every single day in their lives. They're used to it. And what we have seen over the years is that the extreme racist attitudes, the Jim Crow laws, the separate but equal laws have been largely terminated. And what we now have are more overt, embedded laws in the society that may not call out a specific group of people by name or color, but by the way the laws are written and where they're indicated and implicated, certain groups of people continually over and over are targeted out. And here are some examples of what I mean when I say normalcy. African Americans and Latinx people are denied loans or jobs, and they may not necessarily be denied the loan, but their interest rate will be exorbitantly high. They pay more than whites for services, homes, automobiles, unjustly accused of criminal behavior by police. I have a vice of high-end pocketbooks. If I go into a Louis Vuitton store or someone similar, I will be followed. More likely than whites to be victims of police brutality. I really don't need to discuss that, as social media with the advent of cell phones has brought that clearly into our forefront. They're more likely to be imprisoned for longer periods of time than whites who are found guilty of the same offenses. You have African Americans and Latinx people having 2 and 3 year sentences for smoking weed. Public education, once again, depending on your zip code, your school will not have the resources of another school with another zip code. And medical care, ultimately leaving in healthcare disparities. Very clearly brought about and shown with the coronavirus pandemic. Interest convergence.
The state of Arizona has honored Martin Luther King Jr. Day for 23 years, and it has a lot to do with the Super Bowl. 9 on your side, Simone Del Rosario explains.
On Martin Luther King Jr. Day, Arizonans marched to honor the life and legacy of the civil rights leader. But more than 20 years prior, they marched to protest Governor Evan Meekham's decision not to honor the holiday. The decision had major implications for the state when the NFL pulled the 1993 Super Bowl from Phoenix. NFL Commissioner Paul Tagliabue said Arizona can continue its political debate without the Super Bowl as a factor. Super Bowl 27 had been awarded to Phoenix, but because of the MLK controversy, site selection chairman Norman Brayman said How could anybody in his right mind go to play there? Instead, the Super Bowl played out in Pasadena, California. And Phoenix lost out on an estimated $200 million boost the game would have had on the economy. Voters approved the state holiday that year. Fast forward to 2014, Arizona politics once again getting in the way of the big game. Senate Bill 1062 and the right to refuse service, known by some as the Religious Freedom Bill, others the Anti-Gay Bill. Again, the Super Bowl in jeopardy. But former Governor Jan Brewer vetoed the bill, and the state has $500 million to gain. Simone Del Rosario, KGUN 9 on your side.
So here we clearly see that the legal advances or setbacks for people of color tend to serve the interests of dominant white groups. Differential racialization, another tenet.
It's chilly outdoors, but inside. For generations, frosty mornings have seemed warmer with stacks of Aunt Jemima buckwheats. Right. Aunt Jemima buckwheats, deep golden brown with a tantalizing buckwheat tang. It's the same today. Men still need a hearty, nourishing breakfast. And men love Aunt Jemima buckwheats. No buckwheats can equal that famous Aunt Jemima flavor. And they're so easy. Just pour out Aunt Jemima buckwheat mix from the yellow box. Then add milk. Serve with crisp brown pork sausage or with ham or bacon. Lots of lucky men can have Aunt Jemima buckwheats tomorrow if they only ask for them. Men, ask for Aunt Jemima buckwheat pancakes. They're good.
Clearly, we have that stereotype of the mammy, morbidly obese, head-tied lady that still, up until maybe within 10 years ago, stayed on the box of an Aunt Jemima pancake mix. And then we go to that simple-minded, childlike servant. Butterfly McQueen, famous for Gone with the Wind. And then lastly, I want to bring to your attention about the social welfare programs that people of color are often stated to be lazy and not wanting to work. And this has been immortalized forever in film.
Children.
Children, would you cut that music down? Just turn it down. Hello, Mrs. Price. Hi. How you been? Oh, great.
So here we have in Claudine, the social worker has now arrived to the house, and we'll take a look at what happens from here.
Yeah, I would like a queen. Mrs. Price, have you been working? No. Because if you have, I really have to know. Otherwise, you get into trouble. No, I ain't been working. Mrs. Price, you know I'm your friend, but you have to be honest with me. I ain't been working. Well, I understand understand a man's been visiting you regularly this past
You
month.
are not supposed to spy on us.
I didn't spy on you, Mrs. Price, but someone has.
It must be that lady, that bitch across the street. She'll say anything, that bitch.
The thing is, Mrs. Price, if something comes out later and I don't know about it, you'll be in all kinds of trouble. So if you've been seeing this man.
Well, what is this? Am I not supposed to see a man? What am I, a damn nun?
No, but if you've been sleeping with a man and he's been giving you things, I'm sorry, but I have to know.
Do you sleep with a man?
Now, that's none of your business.
It's none of your business either.
You're wrong, Mrs. Price. It is our business. This man may be bringing things into your home which you may not be deducting. Now, you know I have to deduct you on those things.
What things? What things, damn it? You have a man come over for dinner, he brings you a bottle of wine. I have a man come over for dinner, he brings me a damn six-pack. Oh, there are two left, Miss K-Back. Would you like a beer?
I'm sorry, Mrs. Price.
I'm sorry, too. I figured it out. It comes to about $1.35. If he brings my kids some soda, that's about 80 cents. Now, with quick figuring, that comes to about $2.15, Miss K-Back. That's plus tax.
You mean to tell me that only gives you $2.15?
How much do you get?
And there we have it, differential racialization, negative stereotypes. We go now to the next tenet, which is intersectionality, where typically a person that is oppressed or a group that's oppressed actually has multiple different prisms from where their oppression comes from. So for instance, someone can be Black and female and migrant.
Intersectionality is just a metaphor for understanding the ways that multiple forms of inequality or disadvantage sometimes compound themselves, and they create obstacles that often are not understood within conventional ways of thinking about anti-racism or feminism or whatever social justice advocacy structures we have. Intersectionality isn't so much a grand theory, it's a prism for understanding certain kinds of problems. African-American girls are 6 times more likely to be suspended than white girls. That's probably a race and a gender problem. It's not just a race problem, it's not just a gender problem. So I encourage people to think about how the convergence of race stereotypes or gender stereotypes might actually play out in the classroom, between teachers and students, between students and other students, between students and administrators, and commit themselves to understanding that as a way of intervening and providing equal educational opportunity for all students, regardless of their identities. Identity isn't simply a self-contained unit. It is a relationship between people in history, people in communities, people in institutions. So schools do a good job when they understand that and when they commit themselves to curricular development, to opportunities in the school for all students to understand the histories that have brought us to this particular moment. You can't change outcomes without understanding how they've come about. So independent schools can take the lead on that to be responsive to their student populations and to the communities out of which the students come.
The last tenet that I'd like to discuss is the voice of color, sort of a legal storytelling by people of color, where they feel that they are qualified to speak on behalf of other members of their group. They've earned their stripes. They are giving their self-expression of their views of being victims of racism and oppression. In summation, I'd like to say that CRT is a verb. It's not a noun. It is not static. It's not a narrowly defined entity. It's evolving and it changes as society changes. As the use of laws change from being an oppressive mallet to something that is uplifting, CRT also changes. And I want you to understand that CRT is not just about African Americans, but every marginalized group. Thank you.
I'm going to go to our first question, which is, let's see. This is for Dr. Straker. And the question is, what is the impact of gentrification or worsening or solving the legacy of redlining?
Could you repeat that again, Dr. Armstead?
Yeah, can you see the chat, Dr. Straker? This is a question that was posed at 12:47. It's like, what is the impact of gentrification on worsening or solving the legacy of redlining?
Wow, that's a really good question. Gentrification, once again, because of the COVID laws and the way the system has made the laws, when you see gentrification, people moving into these areas now are not people of color. Let's take, for instance, Brooklyn. I grew up in Brooklyn. I went to Brooklyn Tech, and that whole entire area of Fort Greene, Brooklyn was gentrified. It was gentrified by people who were not of color. To this day, it is very hard to own any piece of property in Fort Greene. Same thing is happening now in Bedford-Stuyvesant. I am presently renovating a brownstone in Bedford-Stuyvesant. That was left to me actually by my parents. But for me today as a physician to be able to purchase in that neighborhood would be well out of my means. When I look at the people who are on the block of the home that I am actually renovating, they do not look like me. So gentrification has further continued to impact the already set in motion situations that redlining has started.
All right, I have a, first of all, just wanted to let you know that Dr. Ellis has put some links in as far as his slides are concerned, and also put in the link to the YouTube speech by Dr. Martin Luther King. Having a bit of trouble seeing all of the questions, so I'm just going to.
May I say something, please, Dr. Armstead?
I'm sorry?
May I say something, please?
Yes, yes, absolutely, Dr. Ellis.
Yes, I certainly want.
Dr. Ellis, please speak.
Thanks so much for organizing this. And I just want to comment that I initially gave my talk in a much longer form for the second Andy Ovasapian lecture at the University of Chicago, who was a man who loved his patients, and something that I suggest that we all do. And a lot of this, as for I think all of us, comes from our lived experience, but we have to acknowledge the Chinese Exclusion Act. I think as Dr. Lee talked about the confiscation of property from Japanese American community, the fact that the United States seized much of Mexico, the demonization of Muslims and other minorities, the persecution of people based on their sexual and gender identities, and certainly the treatment of indigenous people over the course of history. So I give a shout out to Dr. Ovasapian, and I thank you for organizing this session.
Well, I put in the chat, anybody who knew Andy Ovasapian as I did loved him too. You're bringing tears to my eyes, because one of the things I noted, he was so welcoming to me within the Society for Airway Management, and he didn't have to do that. So my question kind of goes out to everyone. How can we as anesthesiologists prevent further harm being done to vulnerable populations, such as the ones that Dr. Ellis mentioned, due to what is known about critical race theory?
Well, I think a major impact that anesthesiologists can serve in is at the level of the PAT clinic. Oftentimes, we are the first providers, say for instance of OSA, that we are the first providers that actually diagnose OSA. So if we at that level can intervene in the care of that patient, way before they actually proceed to their surgery, perhaps their outcomes would be better. So I think that anesthesiologists are not just the end provider, but we are also the beginning provider, and we can be of major impact on the care of our patients. Think about diabetes that you see in the PAT clinic that is completely out of control, that we can intervene in the management at that level and prevent all of the sequelae that may come out of that.
I think Dr. Ellis also made the point about protocolizing care. So taking the subjectivity out of it, bearing in mind that we're all subject to bias and we may do things that we don't even recognize. And I think, and as an OB anesthesiologist, I know that in California, instituting hemorrhage protocols resulted in a reduction in disparities in outcomes.
I think it has become more common, certainly since George Floyd, and a wider recognition of these disparities, to have vice chairs for diversity, equity, inclusion, justice in departments. And I think, I'm a little long in the tooth, but for those of you in those roles, one of the things I would task you to do is try to measure these things in your institution. What are the disparities in care in your institutions, be it epidurals for labor and delivery, be it general anesthesia for cesarean section, be it, as in the example I gave, of the long stays after colorectal surgery for Black patients before instituting ERAS protocols. I think that's one of the things that can be instituted locally. Earlier in the chat, Dr. Armstead had asked me, why was it that Black patients' surgery took longer? Was it because they had surgery done by trainees? That's a very hard thing to discern, because obviously in academic institutions, there's often a mix there. How much gets done? It's hard to measure that. But to measure the fact that operations take longer, that people stay in the hospital longer, those are things that could potentially be identified and then hopefully addressed.
I just want to jump in because we have a question from Dr. Demetra Rankin. How do we influence the accreditation organizations and make education about these disparities a formal part of the anesthesiology training?
Well, I was actually very pleased to see, in taking my MOCA questions on the go, that there are actually questions addressing healthcare disparity. And I think that by the fact that these talks and our teachings about healthcare disparity are actually on the boards, that is a major validating system. And that means that we need to start teaching our residents what we're talking about.
Are we out of time? Tracy Katz?
Technically, the session ends at 1:10, but you could go for another 5 or so minutes.
Awesome. Okay. So I have another.
The room will shut down though, just FYI, but you can go until then.
All right. Well, thank you so much. Really appreciate it.
You're
so
welcome.
Please keep your questions coming. And one of the questions actually that I had, because I don't see any new ones that I have for Dr. Lee, is can you comment on, since you're an OB anesthesiologist, can you comment on the term Mississippi appendectomy and explain to those who might not know what that is?
Actually, Valerie, this is something new to me as well.
Okay, well, I'll just jump in there. So, Miss, you had talked about, or I think Dr. Ellis had also talked about not illegal, but incidental sterilization, or those done without permission. And so in a number of the southern states, actually as a method of training, women were subjected to hysterectomies during the time that they were having abdominal surgery. And it was often referred to as a Mississippi appendectomy. So I recommend anyone Google that, because that's just another one of the transgressions that has occurred as a result of institutional racism. And I think I can't remember the name of the Black female activist, but she was actually, Fannie Lou Hamer was actually a victim of a Mississippi appendectomy, was sterilized against her will.
Well, speaking about sterilization, I just wanted to comment that sometimes I get frustrated because I feel like sometimes we've swung in the other direction a little bit. There's so many rules and barriers to getting tubal ligation, and I worry sometimes our low-income women that would actually want, had multiple deliveries and want sterilization. Sometimes the BTL, tubal ligation is not seen as an emergency, and then, they may not be insured, they can't come back and get the procedure. And so I feel like in a way that's almost gone in the other direction. We're in trying to protect women, we've sort of now removed their access to that type of care.
Yeah, I have also found that transportation is a major social determinant of health on many levels. Having worked in rural Colorado, where patients didn't have transportation or telephones.
If I may say something, this follows up on something that Dr. Lee talked about with the VBAC algorithm, and I talked some about in chronic care, that artificial intelligence is going to be dependent on the data that goes in. So just like you have these sentencing guidelines that assume Black folks are more likely to be recidivists, but yet Black people are more likely to be arrested and sentenced for the same crimes, garbage in, garbage out. And so I think we need to be cognizant of these issues in healthcare, that we collect good evidence for example, again, as Dr. Lee talked about, in VBAC protocols. And so I've put in the chat a conference that will be virtual at the University of Chicago Booth School of Business next week on, or is it the week after? It's on algorithmic bias in healthcare, something that's of interest to me. And I think, again, for young faculty, young trainees, is something that deserves our attention.
All right, well, thank you, everyone. We're coming up on that quarter past. So once again, thanks everyone for attending. Thank you all of the speakers for your wonderful, wonderful talks. And hopefully this will not be the last time this subject comes up in any of our anesthesia or medical meetings. So enjoy your weekend, and thank you again for attending.
Thanks for putting this together, Valerie.
Thank you, Val.
My pleasure. Thank you.